And we welcome you here at KSMO Radio, 1340 AM and 95.7 FM. And we have Brooke Bullman, the CEO from the Salem Memorial Hospital in. And we're going to talk to her about, obviously, her first full year here at Salem and some of the things going on at our hospital. And I know, Brooke, a lot of people have not met you yet. So could you tell us a little bit about yourself?
Yes. Stan, thank you for having me. I'm excited to be here and share about all of the things going on at the hospital. I am Brooke Bullman. I came from the South Central Kansas, North Central Oklahoma area. I was born in Kansas, South Central Kansas, and most recently at a very similar hospital in Kansas. I started with a background in accounting and never thought I'd be in healthcare ever. I started as a staff accountant and fell in love with rural healthcare. So there I did my most recent hospital. I did a transformation kind of turnaround project and came here to do just the same.
Now, as an accountant, and I have an accounting degree as well, rural hospitals, all hospitals are really what they call not-for-profit accounting, even though there are some for-profit hospitals. But you have encumbrances, you have different things that go on that funds can only be used for certain things. So even if somebody says, well, a hospital is flushed with money, it may be flushed with money, but that money may have ties to it.
Yes, it may be restricted. You're exactly right. One example of that is our grant funding. We've done a great job of getting grants in the door to help with things like different programs and expanding that capacity, or maybe some for equipment. There's not a lot out there for capital,
Right.
but we try to grab and latch onto that and continue to improve wherever we can. But a lot of it is restricted.
Well, we are glad that you're here, and I wanted to have you come on and really talk to the people about what's going on at our Salem Hospital. Obviously, they've heard a lot of things going on. We know back in 2022, we had some really bad things happen to our hospital, and it's a battle to get through all that. It's just not an overnight thing. You just can't fix one thing and then not have to fix something else, because they all kind of work in tandem at the hospital. Even though there's different departments, they still rely on each other, don't they?
You're exactly right. Yes, it's you're right. It's not an overnight turnaround by any means, but we've made a lot of really great improvements in a year's time, which is almost unheard of. So we're very, very proud of that. We've got a lot of really great momentum and anxious to keep that going.
So I know you just had a board meeting and you did review a lot of the different things in your first fiscal year here.
We
And
did.
fiscal year for the hospital is July 1st through June 30th.
Yep.
So, I'm going to allow you an opportunity to discuss a few things with our listening audience about what has been achieved. And I want to make sure that everybody understands this. It's not a one person achieving this. It's a team effort, because everybody has to buy in to get the same direction to get things accomplished. And you've done a great job of uniting people to get to those goals. So I would like you to take it from here.
You are exactly right. It takes a village,
It
and
does.
not even just the staff coming together and buying into that mission and carrying out all of those visions that we have for the hospital, but also the buy-in from the community. And I will say we've been incredibly overwhelmed by the support and the response of the community over the past year. So much appreciation for that too. Our staff over the past year has done a lot. I tried to recap this in the last board meeting, and there's so much. I almost wonder, where the heck do you start? But things like, I guess I'll start with financial.
Sure.
That's always a hot topic for everyone. Obviously, there's been a lot of attention at the hospital around the financial state, and we very quickly were able to drive down accounts payable. Accounts payable have been let go. The hospital was low on cash, and there were a lot of accounts that were just outstanding.
And some of those were outstanding for over 90 to 120 days.
They were.
Yeah.
Some of them a year plus.
And
So
that's hard to keep creditors that way, isn't it?
it's tough. Yes, it hurts your credit. We work with a ton of vendors that are providing our medical supplies.
Sure.
And if you don't keep them happy, you're in trouble. So we put ourselves in a great position. We've dropped our accounts payable that was aging not just our monthly spend on top of that, but dropped
Sure.
our accounts payable by $2 million, which
Wow.
is a lot.
That's a lot of
That's
money.
the extra cash that we came up with through savings and through increased revenue too. So that is one very high point for financials. Our census has stayed consistent. We've still got people in our beds. We've got lots of outpatients coming in, and I think that is just a testament to the trust and the support of the community and of the patients here in this area.
And people need to understand too, the hospital is cyclical as far as seasons are concerned.
Yes.
Summertime usually is kind of a downtime for hospitals, and
It is.
then you get into the fall season. Of course, winter season is usually big. Somewhere between November and March are usually your best months, but it doesn't mean that you're not going to have that odd month here or there. Well, I think we've seen some flu bugs come up as late as April here in Salem lately in the last couple of years. So, that'll drive things a little bit different. But normally it's about a 6-month strong period and 6-month weaker period
You're
for
exactly
rural
right.
hospitals. Is that correct?
That is
Yeah.
correct. In the summertime, we do see a lot of tourists coming through this area, specifically for the scenic rivers. A lot of the state parks, people are active, and so we'll see patients coming in that aren't necessarily from the region. So that helps to kind of level us
Sure.
out a little. But you're right, our sick season is primarily in the fall and early part of the year.
Okay.
Some of the other things, as far as financials are related, we did cut our operating expenses. We've talked about that quite a bit. We've looked at a lot of our contracts, a lot of the services we were outsourcing, tried to figure out how we could best optimize and sustain what we are already doing. We were able to save in our last year's budget by $3 million in
Wow.
operating expenses. We also had a couple of anomalies that help with our income statement. We ended the year right around $5.5 million in profit, which is incredible for
Sure.
a rural hospital. I don't know that you'd find another one that was able to do that.
No.
But that said, some of that was grant money,
Sure.
which is a one-time instance. We had some insurance reimbursements that played into that. And then we also know that we've got some challenges coming up. We've got looking into the fiscal year 26, our July of 25 through June of 26. We know we've got a lot of contract increases. We're looking at tariffs on supplies
Sure.
and things that we're purchasing. So to say this is going to happen next year, we couldn't.
No.
There's no way. And we're still trying to figure out what one big beautiful bill act look like
Sure.
for us,
And we're
what
going to talk
that
about that
impact
a little
will
bit.
be.
Yeah.
So I think that as we move forward, we're going to have to continue to stay flexible, stay innovative, keep learning how to adapt, and figure out how to rethink rural healthcare.
Right. And some of those contractuals, correct me if I'm wrong, will help you reduce prices on some of the products you need. You make contracts with these people. This is the price you're going to pay, provided you order X amount at a time or something. And you may have had to renegotiate some contracts, especially since some of your creditors were getting not paid
Yes.
for an extended period of time. And then you had to make assurances to them that that's not going to be the case moving forward.
Yes, we've done a lot of renegotiating, reevaluating how we're going about operating and providing some of those services. But we're always trying, to keep healthcare affordable, and we'll continue to do that.
Very good. So the financials have seen a lot of improvement.
Yes.
But that starts also, there's a little bit of attrition in there. We all know that some people left and you hired more people, but you still have some people that'll leave. Maybe some positions had not been refilled or maybe getting refilled here in the next year. Is that right now? You just didn't have the money, you didn't see fit, or the board didn't see fit filling those positions. Those things happen. Those are board decisions too.
Yes, you're right. And we've been in limbo, in all honesty. We've been working through this potential affiliation with Phelps Health.
Right.
And now that those discussions have concluded, we're coming back and trying to figure out, okay, what really is the best direction for the hospital? And so while we were in limbo and not really understanding what staffing was going to look like moving forward, we couldn't in good conscience fill some of those positions
Right.
thinking, hey, which of these are going to be absorbed?
Yeah, and if you did, and Phelps Health had a redundant position, somebody's going to get let go.
Right. And we don't want to do
and
that.
that's not fair to somebody who just got started in that position.
Right.
Talk a little bit about the culture of caring. I mean, that's something Salem Hospital. I know I've been in Salem Hospital a few times. I've had blood pressure issues, and I had COVID, et cetera, et cetera. Everybody always said commitment to caring. The caring is part of it. It's local. It's family. You guys are getting back to that, aren't you?
We are. I've talked a lot in the board meetings. Anyone who reads the paper will know I say this is not the same hospital that it was a year ago. And in many ways, it's not. And in some ways, it still is. That close to home, the touchy-feely experience, that one-to-one, face-to-face interaction that you're going to get with our staff, still the same. They're resilient, and they care so much about the community and the patients that they serve. That's not changing. We're just enhancing that.
And most of your employees come from this area.
Yes.
It may not just be Salem, could be Licking, could be Rolla, but they're coming from this immediate area. And I guarantee you, and I know in my stay at the hospital, if not one time, if 2 times, or maybe even 3 times in a day, you're going to talk to somebody who knows somebody that you know that's in town.
And that's exactly right. That's the expectation we have. We want to treat all of our patients like we would treat our neighbor,
right,
and our mother and our sisters and our cousins, and that's the expectation that patients should have whenever they come into the hospital. And I think our staff really takes that to heart. The Culture of Caring Project is really just about that. We started this early 2025. So this year we started this, and the Culture of Caring Project really started with an emphasis on staff.
Right.
Knowing that we need to further develop our staff. We need to develop those skill sets. We need to make sure that we are recognizing them and rewarding them and taking care of them in all of the ways that are important to them. Our benefits plan, even teamwork, collaboration, all of those things that have been overlooked for so long. So we're coming back and refocusing on staff, knowing that in turn, if our staff are the best that they can be, we're going to provide the best care that we can to our patients.
And you have to do all that within the confines of your financial situation.
Yes.
And sometimes that's just not easy. I mean, we all know that healthcare providers, I don't say all come with a premium, but a lot of times you have to give bonuses to get a great director of nursing or whatever it might be. And if you aren't in the position to do that, you can't do that. Now I say now $5.5 million in the good. Now, grant you, not all of that is just sitting there waiting to be spent. As you mentioned, a lot of it's encumbered by grants. But at least now you have a little bit more flexibility because you kind of know where the hospital is kind of back on some steady ground, isn't it?
It is. And we did. We spent a lot. So of that $5.5 million, $2 million of that, of course, went to old accounts payable.
Sure.
And some of that was earmarked for things like the grants I mentioned previously. But we made a huge investment in the staff. Our retirement plans. We did some pretty significant staff raises. We are way more competitive today than we have been in the last several years as far as compensation goes. So that is all helping. It's improving the morale. You can tell when you walk in the door, culture has a different feel to it.
And as you're doing that, you have to walk that fine line on the finances, and that's where the key comes in. People are buying into what you're doing. You're doing it in an affordable way that's not taxing the hospital, and you're keeping that commitment to giving people the care they need and that hometown feel, and you're doing it all in a slow, progressive way, but you're getting it done. Slow but sure.
Yes. And there's a lot we still want to do. We
sure.
have, we're working on our 5-year strategic plan now,
Right.
and there's a huge emphasis on staffing, recruiting, retention, all of those added benefits,
Right.
that we've been talking about. So I'm really, really excited about all of the things to come for staffing. It's tough to recruit to a rural hospital, a rural community. We're talking about physicians and nursing staff. We're short nationwide. This is a country problem. It's a systemic problem. But how can we make Salem stand out? And I think all of these things we're doing, you're right, taking baby steps in the right directions.
And you got a case manager that follows up on the cases. If something is maybe not right or there's a mistake, they want to follow up, get it corrected right away. You don't want to waste any time. And Kendra Mowbray's back, and Kendra used to work out at the hospital many years ago, and especially in the clinic. That's where I remember her. She's a nurse from the doctor I used to go to. Familiarity. People know Kendra.
Yes. And Kendra's in charge of quality and risk.
Right.
Allie is our case manager.
There you
We
go.
are really trying to meet people where they are and also raise the bar internally. We want that expectation at Salem to be excellent care, not just quality care, excellent, the best possible care that you can find
Great.
in a rural area. So we're very excited about the progress and the momentum we have around quality. We are going to move the needle on that and already have.
Right, right. And you've taken steps forward technology-wise, too. I think you have a new service that actually will text patients, remind them of appointments and things of that nature. Because I know, there's times that I admitted myself, I got up, like, I had an appointment at 1 o'clock and it's 12:55 and I'm still sitting here at the station. I'm like, oh, gee, I didn't have any text reminder or anything like that. You do now, don't you?
We do. Yes, you can get a text appointment. It will remind you once you set the appointment and then give you regular reminders after that until the day of your appointment.
So, again, technologically, you guys are moving forward to
We
keep
are.
the patient on top of their commitment to the hospital.
Yes, and to their health.
Sure,
Just
absolutely.
making people more health conscious.
Very good. All right, continue. I mean, this is a good list. I like
Yes.
this. So go ahead. Continue on with some more of the information you gave the board about different things that are going on. I know you guys have really, I think the long-term care just, again, got rated 5 stars again.
We did. Yes, CMS has named the Salem Hospital Long-Term Care Facility a 5-star facility, which is incredible.
It's amazing.
Those staff back there, Glenda Botkin is running the long-term care department, and she goes above and beyond to make sure that those patients have the care that they need. And it's a very inclusive. I'll tell you, this fall we are setting up a fall fest for our long-term care facility, and they will have stations that they'll go to. They'll be painting pumpkins, and they'll be doing a ring toss, and it'll be more carnival style. And
Good.
so we're trying to get the staff more involved in long-term care as well,
Okay.
along with the community and the patients' families too. But our long-term care is unmatched.
Yeah, it is. And it has been for many years, but that's why people say, well, the hospital's going down, that's going to go down. It has not.
No.
Long-term care has stayed super strong, and again, a 5-star rating, that's better than anybody else around.
We are very proud of that. Yes, we are.
Yeah, so some good stuff there. I was trying to think. Oh, I remember, former basketball player Logan Pogue has come on. He's now in charge of the ED.
He is in charge of emergency services,
Okay.
meaning the emergency department
Right.
itself, as well as the ambulance service.
Almost forgot about Logan, but Logan played basketball here. So I
Yes,
didn't know
and
if you knew that.
Everyone is very excited to have Logan back on. He's been working for us for a long time, had another full-time position and would cover shifts for us. And he just brings the most optimistic and positive attitude to the team and really has that quality mindset as well. So I'm very excited to have him back.
Kind of call him a gentle giant. He's a big boy,
He
but
is.
he's one of the nicest guys you'll ever meet. And he generally is concerned. I know he came in and visited me when I had a little blood pressure issue where I had some pains, and I got admitted to the hospital for a day. And Logan came in. We sat down and talked basketball for about 25, 30 minutes, and that was a love of his. But, this is a love of his, too. He's more concerned about anything that I needed. He wanted to make sure that I had.
Yes.
And that's what you want in your emergency department. People need things if they need to feel comfortable. If you got to stand there and hold their hand, that's fine. And Logan will be one who will do it.
He will do it. He is very compassionate. We've all got this focus on education, which is one thing that we've really started this year, carrying the torch end of fiscal year 26. There's just been a lack and a focus on that skill development. And in a rural healthcare setting, I think it's difficult. We don't see a lot of situations on a daily basis,
Right.
And so making sure that our staff are always ready to respond for any situation, for any patient that walks in the door. And he's got the focus.
He's good. I really enjoy Logan, and I think if anybody ever meets a young man, I say young man, he's not as young as he used to be, but experience. He's still a younger guy. He's still in his 30s. He's just a genuine article of what we talk about being local.
Absolutely.
I mean, he really is. He displays what most people think when they see Salem Hospital. That's the kind of guy Logan is. He's soft, but he's caring. He's convincing. If he has to get mean, I mean, I don't say mean, but maybe if he has to get strong, he's a strong guy, and he can do what he needs to do to get done. So I was thrilled to hear him taking over as that director. So good luck to him. I really hope he goes very, very far in that position.
Yes.
You got some new people on in the IT department. I said, and it constantly changes. IT, man, we all know it. Every single day, Windows 11 updates. You have to get all that done. The hospital just got new computers here not long ago, and already they're going out because you got to update to Windows. It's a never-ending battle, isn't it, in the IT department?
It is. There are constant needs. And of course, now we've got all of these cybersecurity issues that we are trying to combat and make sure that we are staying proactive and mitigating any risk. Especially with changes in administration, we see more heightened risk. And so we've been super focused on that through software applications, through hardware, through staff training, and just trying to make sure all of our information is as safe as it can be.
And I know in the great big beautiful bill we talked about, we are going to talk about a little bit about some different things that are going to happen with it, but they are wanting to see some implementation of AI.
Yes.
And artificial intelligence in the hospital realm, the best that it can be utilized. But that plan hasn't really been organized yet by the state. I don't think they had that done yet. You can get me up to date on that, but which is going to put additional pressure on your IT department.
Yes, it is. You know, AI is very exciting. You know, in a rural hospital where staff is limited and you're always battling this workforce challenge, leveraging technology is huge. And we can tap into productivity and quality care through technology. The struggle is making sure that we do it in a safe fashion.
Right.
All of our equipment, if you think about it, your imaging department, your lab, your emergency room, all has equipment that connects to the internet and it feeds information to the computer. And so it just enhances the risk. Everything is touching the internet. But there's a cost associated with doing that as well. And so we think about these funding cuts through the One Big Beautiful Bill Act, and we think about the added restrictions, the requirements for us to make everything electronic and to make it fully integrated. So if you go to the emergency room in California today, and you come back tomorrow, your medical records are accessible here. Those are all unfunded, and it just adds challenges. The IT department is constantly shifting and trying to better understand how all of those tools and resources come together and affect our system.
And they've been trying to get that kind of health care where you are going to have that nationwide under one umbrella for years. So this has been going on for a long, long, long time, and it's not an easy thing to do because you have so many different healthcare systems out there, and they don't all talk to each other, do they?
Easier said than done. Yes, it is.
I get that for sure. That's for sure. You mentioned a 5-year strategic plan going forward.
Yes.
And you know, one of the things that I've seen some strategic plans in the past where we got some things upgraded. You do have to be very proud that you have MRIs now, you have 3D mammography, you have new equipment in a lot of different parts of the lab now that had to be bought due to some other issues that we all know. But a lot of the things that Salem Hospital has to offer are relatively, in terms of hospital age, new.
They are.
And you don't have to go and try and adapt those to the internet because they're already connected, like you mentioned, which is a big plus because now you don't have to go find some adapter or something to somehow, or buy new equipment because you're being forced to because of this new AI idea that's going to be possibly implemented through the great big beautiful bill.
Yes. You know, and I think, so AI can be great, and I'm really hoping, especially from a revenue cycle perspective, we can put some AI in place to help us with prior authorizations, which is becoming more and more prevalent. Almost every payer is requiring prior authorizations for services, which is a whole nother conversation. We'll save that for another day.
Okay, that's fine. Well, we'll do this again.
But, helping us with billing and automating a lot of those processes that are manual now. I think that there's a place for sure. It's just us developing that level of trust
Sure.
in trying to make sure that the AI we are going to be utilizing, we are vetting. As far as the equipment itself, our big equipment is current.
Yeah.
Which is great. It's all of the little equipment that there is such a need for. Salem has struggled financially for long enough that there's not been that investment in capital, not in the facility, not in the smaller equipment, just some of those large pieces of equipment that really needed to be done because the parts were obsolete.
Oh my gosh.
Or,
Now, before you came, I can tell you the X-ray department, the imaging was a little old.
Yes.
It'd been there 30 years, and it was showing its age. But I give credit to the boards, who have been in the past. They saw that. I give credit to the previous CEOs and administrators that they see that. They did the best they could getting into that position, but then realized we've got to move forward.
Yes.
And saw that and started to make it happen. I give them a lot of credit.
You're exactly right. They did. They recognized the importance in those things and they invested, which is exactly what we want to see. And hopefully we can continue to do more of that moving forward. I think that, what people don't understand is that for a rural or a critical access hospital, there's this capital challenge. Critical access hospitals are set up to receive 102%.
Yeah, but you've been
or 101%.
And you've been sequestered for 10 years.
Yeah, so sequestration takes away 2%. So they reimburse 101% of the cost and take away 2%.
Yeah.
That leaves you at 99% of your cost. Not
cover
what
it.
are we charging,
Right.
but the actual cost to
Cost.
provide the service. So if you're not even getting reimbursed, if you're not getting paid for just the flat cost to provide the service, you don't have the extra
No.
for the capital. Where's that coming from?
Right.
And that's why we lean on the support of our foundation and the grant funding in some of these programs
Sure.
through state and federal governments.
And I've wondered why. That came on in the Obama years. Why has that not been put back by Congress? That 2%. That was supposed to be a part-time deal. That was only supposed to last for
Short
2
term,
years.
yes.
2 years behind.
And it's extended.
And it's still there.
Yes.
And that's not fair to the critical access hospitals because they are not usually in a very high-density population area.
Right.
So for them to keep going, there's a higher cost involved. And they really need that 2% back.
We do. And that's why there are so many supplemental programs that come out through Medicare and Medicaid, through state and federal governments. But here we are talking about potentially eliminating some of those
Sure.
through the One Big Beautiful Bill Act. So we're just constantly, it seems like even with every administration, constantly rebounding and trying to readapt and adjust and stay flexible to make sure we can sustain in
Right.
the rural community.
And that has to be a challenge, not only in yourself, but obviously the board members have to try to be kept up to date on these things because they hear about it, but they don't know the details. I mean, I just learned a little bit about some of the details about the money that could be available in the Great Big Beautiful Bill, and we'll talk about that again. I keep mentioning we'll talk about that in a little bit, but the idea is that, okay, this could benefit, but at the same time, Medicare is going to get hit. There's going to be a give and take in all these things. How's that going to affect the hospital? I don't think anybody can know until it finally is implemented and they find out either this is a bad idea or it's a good idea. And then at that point, usually what we see out of Congress is some kind of, we need to fix this. Unfortunately, and we've seen this in the past, Brooke, and I know you've probably seen it in Kansas, the damage is done. It's just like you don't fix it today and the money starts coming in tomorrow. They fix it today maybe, and it might take 2 years for that to finally be implemented. And that's very difficult on critical access hospitals.
It is. The One Big Beautiful Bill Act, may have some great things in it, but you're right. The fact is, we're not going to know until it is implemented. And some of this we know won't be implemented until 27 or
Right.
maybe even 28. 26 for some of it. There's a staggered rollout for the One Big Beautiful Bill Act. And there's still a lot of unknowns as it relates to Medicaid. We know that they're restricting Medicaid utilization and the eligibility. What does that look like for us? It's anyone's guess.
Yeah.
We don't know. We don't have the information in our system to say what are they doing for work. We don't have any idea.
And when's that going to be implemented?
Right.
Yeah. No date on that yet.
You're exactly right. The federal government pushed some of this out, and now we're waiting on the state to respond and say, okay, here's how we're going to handle this cut to Medicaid. I heard, and I had lots of questions coming to me from family or friends for a long time when this was all coming about, and they said, well, if you're not serving immigrants, then there's not a problem. And I said, ooh, that is a mainstream media misconception.
Yeah.
There's very little that has to do with the immigration. This is really what's going to impact us is the supplemental reimbursement. So we get paid, if you think about it like this is maybe the easiest way I can explain it. If you're a business owner and you are collecting all of your receipts for operating expenses, you're going to settle up at the end of the year when it's time to pay your taxes.
Right.
If you've done a great job of capturing all of those deductions, they may owe you. Otherwise, you may owe them. And that's a little bit how our reimbursement works. And so we try to capture the cost in all of the appropriate buckets that we can and then settle up at the end of the year. Medicare and Medicaid owe us or we owe them.
That's why sometimes it does affect the financials, by the way, when people see it where you may get $1 or $2 million in one big chunk.
Yes.
Because of that very reason.
You have a settlement.
Your settlement.
Yes.
Yes, and some people say, wow, hospital did great that month. Well, a lot of that might be coming from the previous year.
Correct. Or 2 or 3 years ago.
Exactly.
And that's the way
They're not always on time, are they?
And that's another great point. That cost that you're trying to get back, you may not see for 3 years,
right?
Which is tough, to keep operations afloat.
But the costs happen today.
Correct. Yeah. You're paying your staff today.
Yeah.
You're keeping the utilities on today. Yeah, today. You're purchasing those medical supplies and the medications today. You're exactly right. Yeah.
So that money that comes back, it's really devalued money because of the rate of inflation. And the cost of what the products are now, and of course now with tariffs and things you already mentioned that earlier on, how that could change the value of some of the products that you have to order in. And if that happens, if a tariff goes in, there's going to be a little profit margin put on top of that to make sure that person gets a profit, and it just increase those costs. And that's why I think people get a little bit afraid. They see costs kind of skyrocketing, almost out of control. They'll rein in after the market finally settles. Unfortunately, people will get penalized during that time, won't they?
Yes, they will. They will. It's still unknown. I was talking to the board at our last board meeting, and I said, it's very difficult to put together an operating budget because you have so many unknowns, and they're not a few $1,000s we're talking about. Heck, they're not a few $100,000. We're talking about millions of dollars.
Yes.
And so it's just really difficult to put together a budget moving forward and a game plan when you don't have all of the key pieces. One thing I will say is Representative John Hukin is coming down, and he will be on our agenda at our next board meeting. And so we're really anxious for him to come down. We're going to give him a tour, tell him a little bit about Salem, show him around, and hopefully he'll have some information about how the state is going to respond after the One Big Beautiful Bill Act.
We had John on here about a month ago, and he was concerned about the Salem Hospital. I understood that at that time, I think it was just announced, the contract negotiations with Phelps Health were falling through. And he said, one of his priorities when he gets back up there is finding out how he can help the rural hospitals because, when Ellington went out, that hospital closed. You've got a big gap. All right, so now if you go towards the east, you got to wait to get to Farmington or Fredericktown before you have another healthcare facility that you can count on. I mean, that's actually going to be able to take you in with an emergency room. That's a long gap. Anybody who drives down there from Ellington up to here, you're looking at an hour and 10, 15 minutes, and an emergency situation, that's really not even in our ambulance district.
No, it is
so
not.
It has to be another ambulance district that either takes them here or Mountain View or Farmington or Fredericktown. it's a difficult situation for those people living in those areas, isn't it?
It is very difficult. On the other direction, you've got Houston.
Right.
If you're going further south, correct me if I'm wrong, West Plains may be
West Plains.
the next closest. And,
Yeah.
what is West Plains, an hour and a half?
Yeah, depends on how fast you drive. But you have better roads on 60 and 63.
Yes.
You don't have better roads coming out of Ellington to get here. You got 72, 30. I mean, even if you're over Pilot Knob or anything of that nature, yeah, they've got some emergency clinics. That's true, that you can go by for emergency care. But it's not a hospital, and if they have to transfer you, more likely they can. I'll just say, get you temporarily in a place that you can be transferred so that you can be moved safely for your health. That's about all they can do. They can't really do anything else. They don't have the equipment. They're not a full hospital, not critical access. When you start looking at that and how important Salem is, because that's still another half hour to Rolla. It's still an hour over to Houston and down to Mountain View. There's no good quick way down there but 19, and 19's a lot of loggers on that road going up down those hills, and so you don't know who you're going to get behind. And I don't care if you're driving an ambulance or not. You can't pass on a curve where there's a logger. You just can't. You have to wait till you get to where you can see. So, we look at all these situations, and it's just the area we live in. It's nobody's fault. But it's very important that those people receive the same health care that if you lived in St. Louis or Springfield or Columbia. There's no reason that they shouldn't be able to get that same health care.
Absolutely. And that's why, we talked about, you had just mentioned Phelps Health conversations concluding. So this may be a good intro.
Okay.
The board and I sat down and we had the discussion, okay, where do we go from here? Once we concluded the conversations, we came back to the table and decided, listen, there's still a ton of benefit from partnering with a health system, a health system that has more capacity for training, for recruiting. There is recruiting power. They have more power to help us bring in those physicians or to share their specialists.
Right.
And those are some of the benefits. The group purchasing power, we've talked about that quite a bit. They can help us maybe downsize some of our staffing if we have a role or a responsibility. Instead of placing a full-time position for a 10-hour-a-week job, maybe we can share those services and those resources with them and try to save operating costs. So
For both hospitals.
For both hospitals. And so we are still looking at an arrangement like that. Nothing like the arrangement Phelps Health was intended, but more of a light affiliation, a partnership to just expand that capacity.
Sure.
So we're really excited to see where those conversations go. I've started the conversations and reopened the door. I wasn't a part of those conversations when they all started, so it's all clean slate. And
Right.
of course, the hospital is in a much better position. We're much more marketable. We look like a much stronger partner today. And so I'm very optimistic.
I think it's very important for those hospitals you're talking to see that Salem has a direction now.
Yes.
Because at the time, you were on and off with Phelps Health. You really didn't have a direction, as you mentioned. You were in limbo. What direction do we go? Where do we make an investment in our hospital, or do we not make an investment in our hospital because we're going to make these negotiations with another firm?
Right.
It makes it very difficult. And I know the board had to have some just sleepless nights to try and think about this, because you want to do the best for your local people. At the same time, you don't want things to get out of control.
Right.
You want to have control. You want to still have local control of your hospital. I think because we are a hospital district and there's voting members, because people vote, put those people on the hospital board, that those voices need to be heard.
They do. And we welcome anyone to come to the board to the board meetings. We love to see people coming and taking an interest and participating in those meetings. But you're right. With this light affiliation that we're talking about and just partnering to expand our capacity and our expertise and our education, share some of those cost services. With an arrangement like that, we still keep control here.
Right.
And in these conversations, I'm stressing that the pride of staying independent, the pride of keeping that control here. We value things like that personal interaction. Our physicians, a lot of times you see in metropolitan areas, a physician is in the room just as quick as they leave the room. And, or you have these wait times, and that's something we're still trying to combat here locally. And it, at Salem, it's different. Our physicians and our providers, our nurse practitioners are taking the time, not just at Salem Hospital itself or at our Salem clinic, but all of our local providers. They do develop that relationship with you. They take the time to really understand your needs and to customize a plan that works for you. And that's what we don't want to lose sight of. We don't want to lose sight of that face-to-face connection and
No.
that relationship, that rapport that we have, because it just gives us an advantage when it comes to caring for you. And so that's one thing that we're really stressing.
You know, it
It's just
really,
those values.
I really love the way that you say that. You know, we get the doctors, they do take the time here. Your nurse practitioners do take the time here. They talk to the people. They get to know the people. They ask them questions. Yeah, they've got other patients waiting, and yeah, they don't want them to wait too long, but at the same time, they want all the information from you. So give them everything. When we always talked about that when we had interviews before with some of the doctors, that people come in, and then they make an appointment, and they come in, and they say, "What's wrong?" And they said, "Nothing." Well, then why did you make an appointment? You know, there's something obviously was wrong at the time you made the appointment. What is it? Well, it might have cleared up or it might have gone away. That doesn't mean it's gone. It's just, you may have gotten used to it. You may have gotten accustomed to that, or maybe it has just gone into a little bit of a remission. You may still have it, you know, and just so talk to the doctors. Just be honest with the doctors, and that's all they ever, and nurse practitioners. That's all they ever want, and then they can actually then recommend for you something that's appropriate for the treatment of what you have. If you don't tell them, if you hide something, they may give you something that's for the treatment of what you tell them. And that may not be exactly what you have. So I always say, try and write down all the information that if you have headaches, if you have dizziness, if you're lightheaded when you stand up, write it down. When you get in there, doctor, this is my list of what has happened in the last 2 weeks. I don't know why. Now you've got a starting point.
That's exactly right. You know, it's like the old cliche, you can't fix what you don't know is broken.
That's true. It's very true. You know, one of the things, I know the hospital's had this for a few years, is the 340B drug program.
Yes.
And I think people hear this, but Brooke, I don't think they understand what that is. So can you take a minute and just kind of really touch on that? Because it is profitable for the hospital, is it not?
It is very profitable for the hospital. And, you know, this is, again, one area where legislation just continues to change. And I'm getting email alerts every day about conversations being held at the legislative level around changes with the 340B program. So this is a federal program that is meant to aid rural hospitals. What they do is rural hospitals can sign up to participate in the program. They partner with local retail pharmacies.
Okay.
And there's essentially a rebate program. And the rebates that are shared come back to the pharmacy, our local retail pharmacies, and to the hospital. So it's not just profitable to the hospital,
Okay.
it's also profitable to our retail pharmacies. So
Which
we're
is good.
supporting those mom and pop retail chains. And so it's really, really beneficial. Hospitals all over the country are utilizing this program to purchase large capital equipment, to make investments in the facility, to set up new programs and services in the hospital. So it is important. We do a lot of education on our end. I think that there's this misconception that a lot of that cost is passed back to the patient.
Right.
It is really shared between the hospital and the pharmacy to make sure that those facilities stay in your community.
Right. Which is
a
very
benefit-
important.
Yes. What is a benefit to the patient is that, and this is not a one size fits all, but a lot of times patients can't afford name brand drugs.
Right.
And so they're able, through this program, to get the name brand drug instead of the generic. And with generic drugs, they don't qualify in this program. So they really have to be name brand. But it allows us to shift some of them where it makes sense. If you do better, you respond to
Right.
the generic drug. Of course, our providers aren't going to switch that up for you. But if it makes sense, then they're going to do that. And it does benefit. it also gives the hospital an opportunity to purchase our drugs that we're utilizing in our outpatient procedures, in our emergency rooms, in our inpatient floor. We can purchase those for a fraction of the cost that we used to be able to to purchase them. So
Yeah, and people
that's
don't
really the benefit.
It's a great benefit. And, as I mentioned, Mr. Yukon was here about a month ago, and he mentioned that there are some counties that don't even have a pharmacist in their county. They don't even have a pharmacy in their county anymore. Or if there is, there might be one. We are very blessed to have 4. And, I hope people understand that you know how long a line would be if you had one pharmacy and that's all you had, and that's just insane. But also I wanted to talk a little bit about those drugs that the hospital has to buy. Some of those are dated. They only have a very short shelf life, and they're not cheap. But you have to have them on hand and it might be 1 out of every 500 people that come through have to use that drug, but you have to have it available, and you have to have it ready, and it has to be within the date it needs to be used, because when it does expire, you have to get rid of it. Doesn't help the hospital at all, but you had to have it on hand. So there's an expense there. I kind of call those expenses the cost of doing business, but at the same time, that's a high cost of doing business. That's a big area that there might be waste, and there's nothing that the hospital can do about that. Nothing.
That is a great point, and there are not very many people who understand that very high cost of doing business. Yes, I mean, I can think of drugs, $9, $10, $15,000 drugs, and you're right. You don't use it, and you said 1 in 5 patients. It could be 1 in 500 patients, and you're right. It expires, and you may get some very small credit back on some of those drugs for the expireds you turn back in, but most of them you just write off.
Oh, and then you got to buy it again, and then it's probably going to be higher.
Yes, that's exactly right.
And people say, what kind of drugs would that be? Well, you have a lot of drugs that are for snake bites. Specific snake bites. So we do have a lot of copperheads around here, and they have to have that drug there. So if you go in with a copperhead bite, they can give you the antivenom to clear it right up. However, if you don't have it, you're going to have to suffer. They can help you with some other drugs, maybe take down some of the inflammation or the pain, but it's not attacking the venom.
Correct.
And that's why I think a lot of people don't even realize the amount of inventory that our hospital has, and the amount of staying on top of it. Materials management, I've always said their job is so underappreciated at the hospital, but they do an incredible job.
Incredible job. To think about all of the moving pieces that go into a healthcare organization, and those folks who are working behind the scenes to make sure that every needle or syringe or our medication, our supplies, to make sure that there is a Band-Aid everywhere a Band-Aid is needed, it's an undertaking. They are expecting every single department to communicate with them, and to communicate with them well, and to keep those processes in place to make sure that replenishment is there. And a lot of times those aren't clinical folks.
No.
They don't understand medicine, and so then they have this learning curve, and they're trying to understand what supplies are actually needed and coordinate with each of our department directors.
Sure.
And our staff. So they do. It's a thankless job, and they do a great job at making sure we're taken care of.
And it was even more thankless during COVID when gloves and hazmat
PPE,
uniform.
yes.
It hurt me when I had COVID. I was in the hospital, and every time they came in, I hated even ringing the bell when something came out. Just the alarm was going off. And they have to come in and put that uniform on, and then come in and plug in to the unit whatever came unplugged, and then walk back out and take that uniform. I hated doing that, and I said, what a waste of money that is from the hospital, because can we not sterilize these things and use them again? I mean, really, it just seemed like such a waste. And but the cost, as a patient, I'm watching the cost go up, because that has to be passed on. I mean, it wasn't anything the hospital did wrong. It was COVID. That was what you had to do. But man, oh man, Brooke, it broke my heart, because I'm thinking, whoever is in materials management, you got to find these things first, because everybody else is looking for them too. Gloves and all these hazmat uniforms. It's crazy. And those people had to stay on top. And I mean, I'm sure they worked diligently to always try and keep a supply on hand because you never knew when your next supply is going to come in.
Oh, and we've had struggles, with things being back ordered. Recently, we had during COVID, the PPE that was constantly back ordered. They're having to find new vendors. Hand sanitizer was one thing during COVID,
Oh, yeah.
and then we had to start going to alcohol suppliers
Right.
who had turned to start making our hand sanitizer, and they're just constantly shifting and moving. Tariffs just the same. We've seen a ton of shift with supplies and availability since all of these conversations around tariffs have started happening. And IV fluids is one thing that is currently low. And so they try to figure out, okay, how can we keep providing the same care to our patients and also make sure we're being frugal,
Right.
knowing we've got limited supply. And so they've got a tough job. They really, really do.
Really do. I tip my cap to them. It's a thankless job and one you don't get a lot of thank yous for, I'm sure,
That is
from the
true.
general public because they really don't know you're even there.
Yes, that's exactly right.
One of the things you mentioned grants, and I think some people might be more familiar with the Torch grant. They've been hearing a little bit more about that here lately. Which the Torch grant is grants that kind of come through the hospital, but they don't stay at the hospital. They go to other organizations, and it's kind of Medicare based. Am I not correct on that? Has to somehow help serve Medicare.
Medicaid based.
I'm sorry, I
Yes,
did say Medicare. I'm sorry, it is
Medicaid-based.
Medicaid based. Yes.
So the intent of the Torch program, the state of Missouri, and I applaud the state of Missouri. They are taking a very innovative approach with the
Okay.
Torch program, and their whole initiative here is how can we make our Medicaid population healthier
Okay.
and improve their overall wellness and way of life, and in turn save the state money on the cost of Medicaid, which is a great theory. So what they did was the state came out and they asked for pilot programs. They wanted counties and hospitals in counties in the state of Missouri to sponsor these programs and try to work out all of the bugs, if you will, with the program, and two, to see if it would actually work. And so they've given us goals. We're looking at in our ED, our top complaints are diabetes, their COPD, their congestive heart failure. We see a lot of patients coming in with strokes and heart attacks. And so we're taking that data and drilling down to the Medicaid population specifically and trying to figure out what things are really driving those emergency department visits, the inpatient admissions, and trying to figure out how can we strategically go about improving their overall health to reduce that cost for the state. And then any of that cost savings after the 5-year period would come back to the hospital for running this program.
Okay.
And so there's some skin in the game, which makes it kind of fun. But it's a really, really great program for the community. We do have a larger Medicaid population here. And so we're invested. We partner with the community. There's several organizations. We've got the Four Rivers Health Clinic. We've got Phelps Health Clinic. We've got Healthy Dent County at the Armory. We've got the
Health
Dent County
Center.
Health Center. Aging Best, the list goes on. We've got several organizations and constantly trying to grow and improve that program. It's somewhat challenging because there's
Sure.
little guidance and they've left it kind of up to the hospitals and the community boards that are set up to run the program. So in a lot of ways that's nice. We're used to having strings and red tape attached to everything.
But they don't know what's going on in your county.
But they don't know what's going on. So they're
Yeah.
leaving it up to us,
Sure.
which is really, really nice. So, we're doing things like one of the things we've talked about a lot is social determinants of health. And social determinants of health are things like, are you getting meals? Are you getting medically tailored meals? Do you have utilities on in your household? Do you have daycare? Do you have transportation? All of those extra things that add to your health. We had a meeting yesterday and we're talking about how all of those things do affect your health. The
They do.
stress, that leads to smoking, that leads to
Stress.
COPD.
Yeah, high blood
and-
pressure, you name it.
Correct. And
Stress can lead to a lot of different health issues.
Exactly. It can. A lot of comorbidities. And so, how can we combat that on the front side and save on the back side, but also improve the way of life for that population? And so, there's a lot of grants out there. We've got some capacity building grants that organizations can take a part of. One of those, was approved. We added some refrigerators to the food bank, for example, to expand their capacity, and that's what it's about. There's also some funding available if any of the Medicaid population is needing those medically tailored meals. They can get their meals paid for. They can get transportation. They can also take advantage of home renovations. If someone has mold or asbestos in their home and maybe they have COPD and that is adding to that COPD or flaring that, there's money in this program they can apply, and home renovations can be made to remove that.
And it's such a great program, and I think people are still don't quite understand it because it is a pilot program.
We're still trying to understand it.
Yeah, I understand. You had a meeting the other day. You're going to have to kind of go back and reassess a few things, which is okay. Nobody knows how to do it, and as you mentioned, the state is trying to let the counties figure out their own guidance on this to address the issues that are most affecting that county and possible solutions to reduce that Medicaid need. If they can do it, great. If there's ways that can benefit the people on Medicaid, I think that's the whole intent of the Torch program. I think it's a great idea. I mean, but people sometimes, you would be surprised. You won't be surprised, as you've said on the committee. But some people have some very intelligent, out-of-the-box ideas that have not been tested, have not been tried. But, if nobody ever tries it, how do you know it's not going to work?
That's exactly right. I love the Torch program because it really is bringing together all of these individual organizations who are focused on healthcare, who are focused on population health in this area. And we all have the same mission. We're just often siloed. And so coming together and trying to combat that and strategically improve the overall population health together it's really exciting.
It is. So we have coming up, we have the CLIA inspection, which we all know is kind of scary.
We completed our CLIA
Did
inspection.
you done?
We did.
And how we come out?
Great. I am so pleased to share that. Thank you.
Congratulations. Now, the RHC, has that inspection been done yet?
It has not. We are still pending our RHC inspection. We feel really good about that as well.
Okay.
The team's been working really hard to make sure that they've crossed their T's and dotted their I's, and they do a great job anyway.
They do. I feel confident, but you never know what the inspectors are going to find.
This past year, on top of everything else, we went through our long-term care inspection.
Right.
We went through our hospital inspection. We went through our CLIA inspection, our ambulance inspection, and all of those turned out really positive.
Fantastic.
Maybe a little administrative things, just documentation on quality programs or something of that nature. But those are very, very minor in the grand scheme of things. Nothing patient care related. So that in and of itself speaks to the massive
I think
improvement.
when I say the word CLIA, it might just ring bad bells that everybody heard back in December of 2021, I believe, is when that all happened. And we don't want to go back there. But, fantastic. The hospital has got those issues corrected, and that's fantastic. And that just is another positive step. As you're making mention of the other positive steps, if you've got those continuing now in the right direction, everything's good. Reputation means a lot. And, when you have a good reputation of passing your inspections and stuff, then when the inspectors come in, they expect that, don't they?
They do. And, these inspectors have been in and around Salem for a long time.
Oh, yeah.
CLIA inspection is a great example. They came in and they were here when all of that went down a few years ago. And so they walk in the door and they said, oh my, we wrapped up our conversation. They said, what a tremendous improvement. This is incredible to see the progress that you all have made in just a couple of years. So we're very, very proud of that. And I'm really, really, our team is they're behind the mission and they see the importance. They recognize that. They've seen firsthand what happens when that bad publicity goes on, and when
yeah.
you have a poor inspection, a poor survey that comes out. So they're dedicated, they know, they understand, they've learned from that, and we're moving in the right direction.
Right. And the worst thing about, and I'll say this, and I'm in the media business and I hate it, bad publicity is one thing, but when people pass it on, they pass it on wrong.
It's true.
You know,
The game of telephone.
Yeah. when you start to hear Facebook comments, or you start to see this other stuff, or even down at the cafes, you start to hear the chatter, and they really don't understand, and they're talking about things that they don't even have a clue of, but they're
Yep.
making assumptions, or they're making inferences about something that's happening that it's not happening, but yet that suddenly becomes the truth as you move forward. So yes, I don't like to ever put out things bad about any of the entities in town. We don't want to do that. Yes, there's bad that happens in the world. We all know that. And unfortunately, that was one of the things that we couldn't really deny. It happened, but it wasn't what a lot of people said it was. But it still was bad. We got over it. We're through it. We're on the good side of it. We're on the positive, and that's what we really want to keep with, because that's what the direction of the hospital has been. You're not looking back and wanting to repeat what you did 2021, 2022. You want to move forward and get the new things going for 2025, 26 that are going to improve the hospital, like the Flex program. Can you tell us a little bit about the Flex program?
Absolutely. The Missouri Flex program is something that we're participating in. What it's doing is bringing together all of the rural hospitals in the state of Missouri. The state of Missouri is contracted with some consultants who are focused on quality and financial improvements.
Okay.
And we come together with our peers in the state of Missouri who have the same challenges, like things that they're working on, financial and operational. We come together, we talk about what those are, and we try to brainstorm how can we adapt? How can we respond to these new set of challenges? And so that's what it's about. It's about the networking. It's about improving our operations financially and
Okay.
operationally. It's about improving the quality and making sure that we are keeping up with the standards, with the new methods of providing the best care in a rural organization.
Sounds simple.
Sounds simple. It sounds simple.
It sounds simple, but we all know it's not. And not every hospital's on the same revenue cycle. Not every hospital's in the same with the same creditors that you might have, and so the Flex program allows people to actually look outside their box.
Yes. And you have consultants who are coming in and offering advice. You're getting data that you don't necessarily have access to on a regular
Okay.
basis. It allows you to compare one against another and maybe pinpoint an
Right.
area where you can improve, or a service line that's working for one community that we might be able to add here.
Well, very good, very good. Let's talk just real. I mean, we already kind of hinted towards the great big beautiful bill, that we know that there's going to be some issues with Medicaid, excuse me. And there might even be some issues with Medicare. We keep hearing about they're going to run out of money in 2034, and that right after I get started on it. So it's just the way it works. But Social Security, Medicare, we all know that people are on fixed income, so with that, and so that's why that's very important. Medicaid is kind of a similar situation with the state program. It's kind of fixed. It doesn't change too much. When we start reducing the amount of money that the hospital gets out of any of those programs, be it Medicare or Medicaid, it really affects a hospital like Salem, being critical access, where I want to say it's about 60% of your income, if not a little bit more or maybe a little bit less now, comes from those programs. If you start losing money out of those programs, it can really affect your bottom line, can't it?
It does. It affects our ability to do raises, to make sure that we're keeping an adequate stock of supplies, to make sure that we are investing in the facility and the needed medical equipment, and our patient experience. So it's concerning to see what they come up with. You mentioned earlier this $50 billion that's up for grabs, and it's not necessarily up for direct grabs for the hospital. So let me make that abundantly clear.
No, it's not all.
There's these state programs,
Yes.
and like the Torch program,
Right.
for example, and they are looking to grab part of that $50 billion to continue this Torch program. And What I think makes it difficult from a hospital perspective is while that's great and they're trying to throw out this $50 billion to help aid where they've already cut,
Cut.
it's not going back to replenish what was cut.
No.
It's not we're taking this money and we're going to supplement the hospitals for that lost revenue. What they're doing is they're taking this money and they're going to put it into health related programs. But there's strings attached, meaning to get some of that money, you have to add staff to start these new programs and these new services. And then you essentially offset the cost of adding those staff with this program money. So they're expecting you to add to your plate instead of really supplementing where you're already losing that money. If that makes sense. That's hard to articulate.
Yeah, it's really hard to describe. From what I read, 50 billion, but it's 10 billion for 5 years.
Yes.
And then it's separated. 5 billion is going to go toward rural hospitals. 5 billion can be used by other health institutions, which could be anybody. And then that money, that 5 billion, is going to go to the 50 states, or whichever states put in a qualified, again the word qualified, plan to the federal government of how they're going to utilize that money. And a lot of that's with AI and the different things we kind of talked about. So that's all fine and dandy. But now the hospital, which is sitting out here, a little small rural hospital, has got to come up with that plan that has to fit the state plan so that they can even be considered. Yeah, no, that's really kind of tough. It has to be done by December 31st, and there's no guidelines yet. And we're already getting near September. Okay, I know you got all that extra time on your hands now, Brooke, but the thing, but when you really realize the state has to come up with that plan. That may not be until October, and then you got about a 2-month turnaround to try and get that in. I don't know if there'll be an extension put on that or not. And again, I'm just saying what I've read today, that these attorneys are saying it's going to be virtually impossible to even apply for that money this year. You would get in 2026. That would fit the protocol designed by your state, because by the time they figure it out.
Right. And the budget's been passed.
And the budget is passed. How are you going to add to it?
Right. And that's what makes it hard, and we are already spread thin. And not just Salem, but any rural organization. We wear multiple hats. We have lots of jobs. It's difficult, I think, to juggle all of those things. And then you add all of these additional programs. Don't get me wrong. Great programs, great intentions. And we are really appreciative of our state and our federal governments trying to focus on supporting and aiding rural health care. I think when you're already trying to do such a large job and you add all of these regulations and all of these mandates on, and then you think about adding on another program with the limited staff, there's just so many hours in the day, and it makes it really difficult to fit it all in. And not only that, I think from the perspective of an executive leader in healthcare, it often feels like we're losing focus of the mission, which is patients, right?
What it's all about.
What it's all about. Yes, that's exactly right.
Well,
so there's a lot to be uncovered. So stay tuned.
I really appreciate your insight into a lot of these things, and I hope our audience is, because these are things we have not heard or even probably seen too much of in the last couple of years, and where our hospital stands. And that's why I wanted to really get you on here. Our hospital's in good shape. Come on. Our hospital still has some of the finest facilities around. If you need an MRI, or you need a mammogram, or you need anything else, you really would want to go to Salem. First off, the cost is less. The equipment is newer than in most of the area hospitals around. Why would you go somewhere else when you can do it right here locally? And that has always been our concern. We have some doctors used to recommend, even at our, unfortunately years ago, at our own hospital, would send people to someplace else. No need to. We have it right here, and support your hospital, because without that hospital here, things would change drastically. And our hospital does a tremendous job. Like I said, I have been in our hospital 3 times. I got nothing but excellent care every single time. And whether I had chest pains or whether I collapsed at a football game and they got me over there with COVID, and I was there 5 days. Nothing but fantastic care. I won't say anything bad about our hospital when it comes to that. They got me there. They got everything I need to get done. Treated me very, very kindly. That's what I wish my father would have gotten the same kind of care in St. Louis when they treated him like a number and moved him from room to room to room to room for 7 straight days. He had 7 different rooms in 7 straight days after recovering from a fall. The poor man woke up. He said, I keep seeing different wallpaper. And you're just confusing the person. So that's not what you get here. You get a quality care that's not only quality care, it's personal quality care. These people know you. They understand you. They know what you're going through. They live here. They understand what's going on in this town. And what I really appreciate you coming on today is letting people know that our hospital is just, it's not back where it was, but we're on our way back to being a very strong rural hospital again. We're a good rural hospital right now. We're going to be strong again. Give it a little more time, guys. Brooke's only been here a year. But you have done a tremendous job. And I say you, meaning you and the entire staff.
Absolutely.
It is not a one-person deal. We all know that. And with everybody buying in at the hospital, you guys have really created a very good atmosphere there. And I'm proud to say that we have you here and taking charge, and really appreciate what you have done.
Stan, thank you so much for having me.
We really do appreciate it. And we'll try and have you again. We don't have to wait another year. We can have you anytime you want to come on. If you got something good to talk about, let's let our people know what's going on at our hospital.
I'd be glad to.
Fantastic. That's Brooke Bowman, the CEO of the Salem Memorial Hospital, and our interview on this Friday. I should say, not Friday, it's Wednesday, but we're actually recording this for Friday on the air. So we wanted to let people know that stop on by the hospital. If you have any questions about the hospital, call them 729-6626, and they'll get an answer to you. They'll get you the right person who can get you the right answer. That's what it's all about. Thanks again, Brooke.